I'd like to reiterate my appreciation of Dr. Glassman coming out here from Louisville, Kentucky. I've had the pleasure of working with Steve quite closely on several research projects as part of the Spinal Deformity Group over the course of now over 12 years. And I've really learned a lot from Steve. Again, in terms of Steve's background, he's an incredibly accomplished person. He was at Princeton University where he won honors in chemistry. He was AOA at Columbia University for medical school. He did his orthopedic residency at NYU. Subsequently, a spine fellowship at Leatherman, and he stayed at the Leatherman Center now for over 20 years. And he's a professor of orthopedic surgery there, where he's been incredibly productive. Steve's known for a lot of things. He's a world traveler. He's very close to his family. Does a lot of family travel. He's got two sons that went to Princeton. A daughter went to Tufts, and an incredibly tight family. Steve's contributions to orthopedics and spine surgery have really been numerous and widespread. Some of the really important things I think everybody identifies Steve's work with is he really was the first to identify quantifiably and measurably the impact of positive sagittal balance on health-related quality of life. He's done a lot of work with patient-reported outcomes, including minimal clinically important differences and substantial clinically important differences. He's done a lot of work with multidisciplinary evidence development, and now he's one of the leaders in the N2QOD project, trying to combine orthopedics and neurosurgery and working together to try and look at evidence development. He's a real leader in cost effectiveness and comparative effectiveness, and I've certainly learned a lot from Steve over the years about these topics. And he's a leader in healthcare policy as well. He had a major role as co-chair for the Professional Society for Coalition Task Force for Lumbar Fusion to try and work on coverage and reimbursement for what we do in lumbar fusion, and currently serving as the SRS president, and the SRS meeting will be in Anchorage this year. So again, it's my great pleasure and honor to have Dr. Glassman here with us today, and I'll welcome him.
Thanks, Sig and Shane. I'd like to thank them both for that incredibly exaggerated introduction. It's a real pleasure to be here, and it's a little hard to follow John. I don't know exactly where he went. Like John, I've tried to organize a talk that is a little bit more big picture than just the specifics of one component of spine surgery. Given what I do, it's going to be a little bit rooted in spine surgery, but hopefully it'll be of some interest and application to the people that do other things as well. So what I'd like to talk about is a little bit about transition and transformation and what I've seen over the 20 years plus, I guess, now that I've spent in this field. These are my disclosures. Okay, so change and progress aren't the same thing, right? This transition from horse and buggy to motorized vehicle was not only change, but it was really progress, right? It changed the way the world worked. But this is a car in 1960. And this is my Lexus in 2009. And there is no doubt the Lexus is better, right? Because it's got four-wheel drive, and it's got, well, air conditioning, the most important invention in our lifetime. I mean, it's just better. But, you know, is it really transformative? You know, probably not. This is transformative, right? And so here in California, and for all those of us in medicine, a lot of times I give this to a group of residents who have no idea that at one point in time you had to stay in the hospital because there was no way to talk to anybody if you got outside of the hospital. But, you know, I mean, clearly this has been the you know, basis of our revolution over the past 20 years. And it came with this thing that'll be familiar to all of you probably, this idea of Moore's Law, where you get every couple of years twice the power at half the cost, right? And as we look at what we've done in medicine, we ought to keep in mind that that's sort of the expectation that was built into advances in technology. And it certainly worked for computers where that everything that fit in that room all of a sudden fits in a laptop. And then there's some things that didn't work out exactly like we thought, because when I was a kid, it was pretty evident that nuclear power was going to be our future, and we were going to stop having oil imports. When I first got my car, it was the oil embargo in the early 70s, and we had to be on these incredibly long lines to get a tank full of gas. And, you know, the thought was nuclear power is coming, and we're not going to have this anymore. But then in 1979, there was this glitch with 3 Mile Island, where there was a little bit of leaking and not a lot of people got injured, but it made everybody worry about nuclear power. And then, you know, in 1986, there was Chernobyl, where people really did get injured, and it you know, set back the advance of that. So this was the first time I gave this talk in 2011. This was the discussion about nuclear power, but it had been since 1986 that anything substantial had really gone wrong. And the morning that I was giving this talk for the first time at Northwestern, or a version of this talk, I went into the Starbucks to get some coffee on the way to the lecture, and this is what was on the television, right? And I had no idea that it was going to fit in so well with the talk that was coming a half hour later. But you know, as we're all aware, this turned into Fukushima and our latest, you know, real hitch in the idea that nuclear power is our future. So not everything goes the way we think. But what I'd like to do is look a little bit at sort of what's happened with spine surgery over that period of time. So we'll go back just for a minute, back actually 50 years. This is a guy named Yves Cottrell, and he was one of the developers of something called Cottrell-Dubussé instrumentation. He was a real pioneer in spine surgery, and this is a book that he wrote and was kind enough to give to me, and it includes how they took care of patients with scoliosis 50 years ago, which was you put them in a cast, and you operated on them in a cast, and you put in bone graft to try to get things to heal. And then they sat in their stretchers, in their mobile beds on the beach, and it was a beautiful beach in the north of France, for a year, right? And that was their treatment. And then along came what I think is the first and arguably the only real transformation in spine surgery in the next 50 years. Well, actually, I'm not going to argue that it's the only one, because the lecture would be really short. But Harrington came around with the idea of a Harrington rod instrumentation where you could fix the spine. And it gave you powerful correction, it gave maintenance of alignment, and most importantly, it gave you mobilization. The kids could get up and start to walk around. And it took us from the days of Hibbs and Albee, who did the first fusions, to the days of Winter and Kostwick and David Bradford, who all of a sudden had the capability of treating idiopathic scoliosis and adult scoliosis and fractures and tumors. And it really was transformational. It didn't work out exactly how it was designed, because it was a system that was designed in 2 dimensions. And it gave 2-dimensional correction. But it turned out that wasn't completely good, and people got these flat back deformities. And so for me, the second transformation in spine surgery was a transformation of understanding. It was starting to understand the spine in 3 dimensions. Now, none of the things I'm going to talk to you about belong to one person, right? But to the extent they belong to one person, the person who probably gets credit for this is someone named Jean Dubussé. He's the other half of the Cottrell-Dubussé instrumentation. And he brought not only instrumentation, but he brought an entirely different way of thinking about the spine. And one of the things he talked about was this cone of balance. And it's really a pretty intuitive idea. If you're standing fairly upright, it takes relatively little energy. But if you lean and you're outside of this cone of balance, it's uneconomical, and it takes a tremendous amount of energy just to stand upright. And this is Jean-Pierre Farcy, who was my mentor at Columbia. This is the first paper I ever wrote back in the early 90s, looking at the sagittal index, the sagittal alignment, and how it affected treatment of burst fractures of the spine. For a long time, I thought that you had to be French to understand these concepts. These are 2 other famous French spine surgeons. But I've come to believe that that's not really what it is. What you have to do is drink a lot. So you might be able to do that here in Northern California. When I started, spine deformity was divided between scoliosis and kyphosis. So a deformity in the frontal plane and a deformity in the sagittal plane, and those were thought of as completely different disease entities. They were just different problems and thought of differently. And this is the paper that Sig was referring to, where for the first time there was a database that allowed us to look at this concept. The concept that sagittal plane mattered wasn't my concept, but I found a database where you could demonstrate it. And this is one of the first studies that looked at the correlation between radiographic parameters and health-related quality of life measures. And we had about 300 patients, and we looked at a whole variety of things. One of them was coronal balance, what people thought about most in terms of scoliosis. And there was a little bit of a correlation between coronal balance and symptoms, but it was really sagittal balance that had the dramatic correlation across all the parameters. And so the conclusion of the study was that sagittal balance was the dominant predictor of health-related quality of life in adult deformity. But importantly, not in kyphotic deformity, this was in scoliotic patients. And so it sort of started to bring together the fact that these weren't different disease processes, they were just different expressions of the same problem. A lot of additional work has been done in this area. This is Frank Schwab from NYU, who's really advanced this concept and developed a classification based on that. And at the same time that the thought process developed, also the ability to impact it developed, because there was a lot of progression in the instrumentation that we use to fix the spine. And we think of it mostly these days as screws, but it is in fact not just screws. This is Eduardo Luque, and he developed something called the Luque instrumentation in Mexico City, right? So very low tech, wires under the lamina of the spine that gave you segmental control and allowed you to control the spine not only in the frontal plane, but in 3 dimensions. This is another example. This is Al Crawford. He was from Cincinnati. He developed something called we call it the chicken Luque. So instead of putting the wires under the lamina where the nerves are, you put them through the base of the spinous process, but same concept. Very economical and effective way of controlling deformity. At that time, right, pedicle screws sort of came on the scene. This is a picture from very early in my practice. And really where they were thought to have the most impact was here in the lumbar spine. They provided fixation in an area that wires and hooks couldn't provide fixation. They provided an improved fusion rate, and they provided control of lumbar deformity, right? So the question, even though they're so widely used now, are they really a transformation, or really are they just an incremental improvement and a transition? And I struggle with what I wanted to call them, but as much as I'd like to say that maybe they weren't a transformation, I think in fact they really were. And it's mostly about deformities in the lumbar spine. So this is a patient with spondylolisthesis, so a substantial slipping forward of L5 on S1, and it's something you just couldn't control without screw fixation. So this is a patient who came to me with foot drop and not able to stand up straight and a lot of problems. And we did this operation, and we realigned him, and we took the pressure off the nerves, and he really had a good outcome. And he had such a good outcome that when on his follow-up visits, he brought his mother in. And this is his mother, who has the exact same deformity, but 40 years ago, she had a non-instrumented fusion, no pedicle screws, so fused in the position that she lay. And so she has a very solid fusion, but she's standing, as you can see, with her body totally out in front of her pelvis, so she's very unbalanced. And this is, to me, mother and son, sort of a real demonstration of how screw fixation just dramatically changed our capability to address that kind of problem. This is another more modern example. This is a woman with significant coronal deformity, but that's not really her problem. Her problem is the sagittal plane. You can see she's lost her buttocks, she's bending her knees, and she's still leaning forward, so she's very unhappy. And we fix her, and it's not straightening out the curve that makes her better. It's straightening out her sagittal plane and giving her her lumbar lordosis, her sway in her back and her butt back, and she's not bending her knees, and she's standing up straight. So, that's something that could only be done with pedicle screws. These are two of the gentlemen who really had a big impact on our understanding and use of screws. This is Dr. Suk from Korea, who's the person that introduced the use of pedicle screws really outside the lumbar spine. And this is Larry Lenke from St. Louis, who's sort of widely been credited with popularizing this. And, you know, this is an example of something in the thoracic spine that you know, these severe deformities, you really can't correct those without screw fixation, so you have, you know, really good pinpoint control of those kind of osteotomies. But for much of what we do, right, this is a, I don't know, $20,000 construct with all those screws. And this is a much simpler hook fixation construct. And for this kind of thing, I don't really know that this is any better result than this is. So screws are important, but I think we haven't quite come to the equilibrium of how we're going to use them. And then there have been some can't-miss technologies that didn't work out so well. For those of you who remember it, this is Betamax, I think. And we have those in spine, too. These are cylindrical fusion cages, and in the early 90s, there was something called the cage rage, where everyone was absolutely positive that this was taking over the world. I had the chief executives of some of the implant companies tell me, we are not making screws anymore, everything is going to be treated with these cages. But just didn't work out that way. It turned out you could put them in, but it turned out they came out too, and they wandered around all over the place. And also, the application of them was at times fairly random. So that was a technology that everybody really thought was going to be fabulous, and it just wasn't. This is another example. This is an interesting example because of why it didn't work out. This is lumbar disc replacement. So lumbar disc replacement was, again, something that was going to take over the world. And firstly, it had a problem conceptually. So right, if I tell you motion is better than fusion, that makes a lot of sense. And hip replacement is sort of the model of this, right? So this is a patient with a hip fusion. And if that patient walked in the room, every single orthopedist and probably all of us would look at that patient and say, that patient has a hip fusion because they can't walk and they're lumbering and they have a terrible gait, right? And so if you give them motion, you've done something tremendous for them, right? This is the operation that disc replacement replaces. It's a single level fusion, and while theoretically it'd be better to have motion than fusion, if anybody in this room had a single level fusion, they'd be walking around and you'd never be able to tell them apart. So the bar for seeing the improvement with disc replacement is really high. A lot of people thought the problem and the reason it wasn't going to take off was because of the risk. To put it in, you have to move the great vessels out of the way, and there's a lot of concern that if you ever have to go back, it's going to be a nightmare, and that has some validity, but that isn't why this didn't take off either. This is why. CMS, Medicare, this is an operation that was designed for young people. Osteoporosis was a relative indication. The trials were all in young people. So when the data came out, Medicare said, that's fine. This is a perfectly good technique. It's just not for our patients. We don't approve paying for it. Older patients were an exclusion in the studies. And then all the private insurers who do cover young people said, Medicare doesn't pay for it, we're not going to pay for it, right? So it was just a glitch in how we pay for things that led to this not really being used at all because the data on it's actually not that bad. You know, you have to keep in mind that it's not just technology, it's how you use it, right? For those of you who don't recognize it, this is a toaster. It's a wonder of modern technology, right? It's simple, it's effective, bread in, toast out. But if you stick your fingers in it, right, you still get burned. So you know, it's not just the technology, it's what we do with it. And we've done a lot of things with our technologies that have not necessarily been so good. And you can get bitten by that. So I think if we look at what the fourth transformation for me in spine surgery is, it's really safety. We've had tremendous advances in medical management, in anesthetic capabilities, and in surgical decision-making, and those have all really made a tremendous difference in how we work. This is how we did neuromonitoring when I started. It's called a wake-up test. So this is how it worked. First, you woke up the anesthesiologist, and then you asked them to wake up the patient. And it was always a little bit scary. Was the patient going to jump off the table, or what was going to happen? So, and we had other neuromonitoring capabilities. We had somatosensory evoked potentials, and those were somewhat helpful, but they didn't really tell you about what you wanted to know about. We had EMG. So this is a way to look at screws. You put a little electrical stimulation into the screws, and if they're near a nerve, you get an EMG response. This is a study that I did, I don't know, in 1995, where we looked at the thresholds for stimulating screws and actually demonstrated that it was more effective than X-ray in telling you whether the screws were in a good position. And that's still widely used today, and it's a good technique because it's cheap. If you can do EMGs, you can do this. And that's still widely used. And the key now thing that we use is motor evoked potentials. And this is, again, long ago when I was in that lab that John talked about. And we looked at the anesthetic effect on motor evoked potentials, and we made scoliosis in rats. We tied their scapula to their pelvis when they were little bitty rats, and we let them grow, and they developed a structural scoliosis. This was the hardest thing I ever had to get through an IRB. The IRB for this rats was way worse than any human study ever. And then we'd straighten it out, and we'd see the threshold of whether you could monitor their injuries with these MEPs. And now MEPs are very widely used, and really what we use is what we call multimodality monitoring. This is Enser Transfelt and John Dormans, both of who have written and talked a lot about this, monitoring all these aspects of the cord, and it's really made deformity surgery much safer. So I think, you hesitate to say standard of care because that implies legal issues, but this is absolutely best practice for spine deformity correction. This is some data, in this case from Larry Lenke, looking at the validity and reliability over 23 years, which is excellent. This is something interesting that the SRS and POSNA, which is the pediatric group, are doing at present. This is a checklist response to neuromonitoring changes in the OR. So this is the same thing that pilots do, right? When something goes wrong in the cockpit, they don't look at each other and think, what did that senior pilot I work with tell me I ought to do when this engine goes out? You know, they have a set standard list of things that they're going to go through and they're going to do, and there's probably reasonable evidence that we ought to be doing that kind of approach in the OR as well. I think the future includes radiographic monitoring. This is what's called an O-arm. It's an intraoperative CT, right? So this is a screw that's not in the canal. You're not going to get it with a MEP, but it's poking into the aorta, which is not so good, and you can see it on an intraoperative CT scan. At the moment, it's expensive and hard, a little hard to use, but that's all going to improve. So I think safety is a big deal, and I think it's really getting better. I'd like to change gears a little bit and talk about one of the other things that I think is a real substantial change over the time course of my working in spine surgery, and that's how we measure surgical outcomes. So this is 1990. There I am with red hair and a little funny looking, and this is what we did. We did these lumbar fusions, and this is how we assessed outcome. The doctor said how the patient did, right? And you could be fair or good or very excellent or very excellent, and almost everybody was either very excellent or excellent. Yeah, we recognized complications, but only big complications, like if your heart stopped working or something along those lines. We looked at fusion rate. That was really our key measure. Of course, we weren't actually very good at telling if things were fused, and it turned out it didn't really affect outcome very much. So now we've moved into this world of health-related quality of life measures and utilities, levels of evidence that we've talked about over the last couple of days, what we call evidence-based decision-making. And that's absolutely progress sometimes. So I want to give you an example. This is, John talked and really a great talk on how data doesn't always tell the story. So this is the sports study. Sig was a participant in the sports study, right? Yeah. This is the best study ever done in spine. This is a $23 million multi-center study with RCT and observational arms, and a lot of surgeons thought this study was designed to prove that surgery should never be done. So data was collected over a long period of time for 3 different diagnoses, and it was a really well-conceived, designed, and executed study. And then when it came to publish the data, the perception that all the investigators had that surgery was performing really well in this trial isn't really what came out in the paper. This is the first paper in New England Journal, and the conclusion was that superiority or equivalence of the treatments isn't warranted because the intent to treat analysis that they utilized didn't really show improvement. Well, intent to treat means that you examine the outcome of the patient in the arm that they were randomized to, not necessarily the arm they were treated in. And that's a good system for drug studies where patients often get half their treatment of one drug and then are flipped over to another drug, right? So they've really gotten both treatments. That's not how it works so much in surgery. And they also published, along with it, the as-treated analysis. This is the treatment that the patients actually got. And it showed that surgery was better, but the conclusion was that you couldn't tell if this data really meant anything because it wasn't the intent-to-treat analysis. So rather than evidence-based decision-making, a lot of us thought that this was more like decision-based evidence-making. And so we can see the application of this to spine surgery. I'm going to go through with you for Praveen, the Kentucky skydiving outcomes trial, just so you see how this works. So we're going to randomize 10 patients to parachutes and 10 patients to no parachutes. And it turns out there's some geniuses in this group who realize that they'd rather have parachutes, and they're going to cross over into the parachute group, all right? And for whatever reason, there's some people who think that they would be better off crossing over into the no parachute group. So you get crossover in both directions. This is one of our guys crossing over into the no parachute group. And so in the end, what you have is you have 12 patients who go out with chutes and 8 patients who go out without chutes, right? And here is our as-treated analysis, right, where the 12 patients with chutes live and the 8 patients with no chutes, they die, right? And I think you could look at this and be pretty sure which group you wanted to be in. But if you look at the that's the as-treated analysis. These all live, these all die. But if you look at the intent-to-treat analysis, which is what JAMA would have you do, right, you see that in each group, 6 live and 4 die. So it really doesn't matter whether you jump out with a parachute or not, right? And that's how they asked us to look at this data. Now, fortunately, we've outlasted them, right? So the data has really maintained over a long period of time. The surgical outcome's better at 2 years. It's better at 4 years. And this data, which was, a lot of us think, designed to prove surgery doesn't work, has turned out to be the best data for surgical treatment for well-selected patients. This is not a diffuse recommendation for surgery, but for spinal stenosis, for disc herniation, for spondylolisthesis, this has really demonstrated outstanding outcomes. Okay, so we talked a little bit before, you know, what we want to do is optimize quality. And we can look at the way that around the world people optimize quality, and it's you know, sort of represented in this Six Sigma approach that I guess Sam Biederman talked about yesterday, right? Where you want to do something the best way you can, and you want to do it the same every single time. That's not exactly how surgeons do it. We have the art of medicine. And sometimes that's really good, and sometimes not so much. So I think as we look forward, right, that we're going to be held accountable not only for efficacy, but for other things as well. I think the bar is going to be higher. And to some degree, we've earned that. And to some degree, it may be a little unfair as you look at issues like new technologies. So this is the concept of innovation. This is how the government sees innovation when they're doing it. Okay? This is the Washington State Department of Transportation, who will point out to you that innovation is establishing an environment that inspires creative ideas and actions. Sounds really good, right? This is how they view innovation in the private sector. You know, it's like an incremental change to be able to sell a new product. And this is how they view innovation in spine surgery. And to some degree, we've earned that, right? Because if you remember back to this Moore's law of every couple years we're going to have something that's twice as good and half the price, that is absolutely not what we have done, right? So in the future, we're going to be held accountable not only for efficacy, but for cost effectiveness. And conceptually, that makes a lot of sense, right? Is a treatment more expensive than the available alternatives? That ought to be something that we're accountable for. Cost and benefit can be hard to measure, right? This is Sig, and he's enjoying this little teeny bite of these things which cost a fortune, right? Is that good? Yeah, it's really good. Is it cost effective? I don't know if it's cost effective. So how do we define value? Cost versus benefit, right? It could be that we look at our health-related quality of life measures, an improvement of ODI of 15 points, and we say, what do we pay for that, right? That would be a totally reasonable way to measure cost effectiveness. It's not how we do it, right? We do it with this thing that Joel Saul talked about yesterday called QALYs. Quality adjusted life years. And that's how it's going to be done, because that's how the healthcare economists do it, and it doesn't matter whether we like it, and it doesn't matter whether it makes sense to us. If we don't learn it, we're not going to play in the game. Okay? So I'm going to go through with you, this was talked about yesterday, but I'm going to explain it in a little more detail, and hopefully you'll see that it's not really so foreign, right? So this is a QALY, it's a health utility. It's a measure that incorporates value and patient preference and durability, all things that we ought to be held accountable for. And the way it works is that it's a scale from 0, which is death, to 1, which is perfect health. And if you start at 0.5, and I have an intervention that improves you to 0.6, and I hold you there for 1 year, you've gained 0.1 QALY. Okay? That's the calculation. It's pretty simple. And you get it from a variety of sources, the most common being the EQ5D or EuroQol, which lets you calculate, is a health utility. You can get it out of the SF36 from something called the SF6D. We've developed a way to transform it from the ODI. And just so you have a ballpark, right, so this is the primary currency for healthcare economics, cost per QALY. And if something costs certainly less than $50,000 per QALY gained, maybe $50,000 to $100,000, it's considered cost effective. There actually is some literature now that suggests that in the US that number ought to be higher, but I don't think we're going to see this. I think we may end up at 100,000, but I think 50,000 certainly is a number that would be reasonable to keep in mind. And it's a good measure because it's applicable across specialties, okay? It includes patient preference, and it accounts for efficacy and durability, right? All things we want to be held accountable for. I'm going to give you just a quick example so you can see how this works. This is a study we did looking at single-level lumbar fusion. We follow people for 5 years. We measure all their health-related quality of life measures, and we measure all the costs associated with their intervention, everything that happens every doctor visit, right? And you see that in year 1, that you've spent most of your money, right? And you've gotten a little bit of your value. But by year 5, if you keep your improvement and you don't keep spending more money, you get increasingly cost effective each year. And so this has a cost effectiveness of about $30,000 per QALY, which is very cost effective. So, you know, this question of how we're going to define value, you know, death panels, right? And death panels sound bad, but the fact of the matter is we need death panels, right? Call it what you want. We're going to have rationing. We can't afford what we have. If we're going to ration care, rationing it based on what works and what's effective isn't the worst way to ration care. You know, I think we hear it all in it, and it sounds like doom and gloom. But But it's not really doom and gloom, because for all the things that we've tested, that we do, that we know are good interventions, they come out pretty cost effective. So we're going to have to look to the future too, right? And where are our next transformations going to come from? So this is one possible pathway.
What, Moses? We are fucking lost.
So it's possible that it's GPS that's going to be our future. I'm not really completely sure. So there are a lot of things in spine that may hold a lot of promise for the future. It may be genetics, it may be non-fusion technologies, it may be, disc regeneration. But I think one of the important things, as we look to the people that are now, residents and fellows to answer these questions for us, is to look for transformations, not to look for a little bit of incremental change that costs twice as much. And I think if we keep our eye on that ball, we're likely to be going in the right direction. Thank you very much.
What I think we'll do, that's a fantastic lecture, Stephen. Let's go ahead and have a few questions for Steve right now, because we've got several more papers in this informing session. But I thought that was absolutely both thought-provoking and inspirational. And to that end, I'll start with a question in terms of, what do you see as being the major barriers right now to the adoption of new technologies? And I'll identify a few. One is the FDA and actually regulation of new technologies. Another is paying for new technologies. And the third is at the hospital level and materials management groups. What do you think is a major barrier, and what's the most effective way to get new technologies approved?
Well, so, I think there's a tremendous suspicion about new technologies in spine that we have earned, because 90% of our new technologies, every screw that's a little bit different, right, and a little bit more expensive, that doesn't really change patient outcome. We've done a lot of that over the last 10 or 15 years. And I think that we are going to be held to a standard of that something has to improve patient care if it's going to cost more. And you know what? That's not such an unreasonable standard, right? I think that at the FDA level, I think we're going to really we're going to struggle with new technology, because they've set up the rules that you have to do very expensive and involved and long studies to really, get something new. To clear something new. And so part of why we've had these little incremental changes is because there's a pathway through the FDA for little changes that's not too onerous, right? And, I think that there's also a real disincentive to physicians taking part in FDA studies looking at new technologies, right? If FDA studies are hard to do, right? They take a long time, they take a lot of effort. And if you think about who does FDA studies, historically, the inventor of a technology did FDA studies, right? But I think we've generally come to the feeling that that's not good, right? That person has a lot of bias about whether this technology is going to work or not. I think that people that have other relationships with manufacturers do FDA studies, and you can argue whether that's good or not. And I think academics have done FDA studies, right? And the reason was because it was a really good way to get your hands on a good data set that you could talk about and think about and write about. But now we've gotten into this mode, at least in spine, and I think in drugs too probably, right? Where if data is industry related, it's not good high quality data, right? And first of all, I think that's incorrect. And secondly, I think that's a tremendous barrier to academic centers having any interest in doing FDA studies. And I think, if you're cynical, you'd say, on Fox News, you'd say it's a conspiracy, right? If you're not cynical, you could say it's sort of the way things have worked out. But I think there's going to be a big tamping down on new innovation, because it's going to be very hard to get people to do the studies that will tell you whether something's really good or not. So on the good side, right, I think there is an absolute recognition by payers, by Medicare, by the government, by private payers, that if they want to drive a healthcare system based on evidence, right, that RCTs for every point you want to prove are completely unrealistic, right? I mean, there just isn't enough time or money or anything to do an RCT for each technique, each surgery, each medical intervention that you want to know, does this work, right? And there's much more of a acceptance of cohort data as driving decision making. But the glitch is it's got to be high quality cohort data, right? So registries or something along those lines, I think, are a likely way to drive data collection and decision making. And it is somewhat hard and somewhat expensive to collect that data, but orders of magnitude less than RCTs. But the problem with registries is if you have 50% follow-up, you have nothing, right? So the problem with registries has been, you know, you can get 3-month data and have 90% follow-up. You can get 6-month data, but, you know, we need to have a year data. We need to have, you know, for some things, 2-year data. And if you get people who enroll in your registry and then don't follow up their patients, it contaminates the entire data set. So I think the key is going to be incentivizing people to participate in registries and really participate effectively in them. And I think that I wish I could say the AAOS is at the forefront of this, but they're not. AANS is at the forefront of this. The neurosurgeons have done a much better job with innovative strategies like discussions about tying registry participation to maintenance of certification, giving people real motivation for doing this and doing this well. And I think that's how we get there.
Just one question to follow up too. I'm a little bit worried about when you talk about innovation and, you know, the financial forces against innovation. If you look back 50 years, we showed some examples of some international real thought leaders, but over the last 10 to 20 years, it feels like cardiac surgery, neurosurgery, orthopedic surgery, the real innovations came out of the United States. We're going to tamp it down here. Europe is already, from what I'm seeing globally, not a leader anymore in coming up with new ways to do things better. And the U.S. looks like it's headed that same way. So where is it going to come from? Are we stagnant here?
Maybe. I mean, I think that's a problem. I think it's a problem. I think we're going to have trouble innovating, and I think it's a little bit of a self-inflicted wound, right? Because what we've called innovation hasn't really been innovation. It's been a widget to do something that we're doing fine a little bit differently at a higher cost, right? That's not going to be sustainable, right? I think real innovation will still be successful, but I think the road to getting there is going to be more difficult because outside of, you know, our own group, I think our idea of innovation is looked at pretty skeptically.
Steve, awesome talk, and I really like the way you painted the global picture and the model of it. I wonder, safety is obviously a big concern. Within the quality model of economic feasibility, is there an additional way to look at that for safety? So what I'm asking is, you know, how many complications do you have to prevent before something is then economically viable?
I don't know that I've thought about it that way, but my, just in 2 seconds, thought about it is that will actually be pretty easy to show because complications are so expensive to take care of, right? So I think adding a component of your treatment that reduces complications will make it much more cost effective. And, you know, this idea that cost effectiveness is something, you know, bad that's going to hurt us, that's just meant to prevent us from doing things. I would just point out that every time a study's been done that doesn't model it and sort of make up what the parameters are, but really measures the parameters for the things that you and I think of as our good treatments, it comes out looking very cost effective. Orthopedics, neurosurgery, spine in general, the burden of baseline disability is tremendously high. And so the potential, if you make that better for something to look cost effective, is really good. Compared to a lot of other specialties, we're at a real advantage in this system that's been set up for us to play in, right? Our only disadvantage is that we don't collect the data, so we don't have the evidence to make the argument.
Thank you very much for your thought-provoking presentation. One thing you haven't touched on is we take a very egalitarian approach in these procedures that are done around the United States. And what we see in Europe are what we would call centers of excellence, where people are referred to specific cities or facilities. We looked at our data for total joints in our 5-hospital system in Sacramento. We saw a wide variability of physicians who did 10 total hips per year versus the man who did 100. And the American Head Orthopedic Surgeons and North American Spine Society, you may remember about 10 years ago was this concept of developing centers of excellence, which has been done in the cardiac area, and the data looks very interesting. None of our academies came out in favor of that. And I think one of the things to keep costs down and infection rate down and complications is that patients need to be referred to centers of excellence, like your facility or any of those around the country. We don't do that. We have physicians doing procedures they shouldn't be doing, taking on complicated cases they shouldn't be involved in, and then your centers deal with those problems. Could you address that?
So I think there's clearly something. So the insurance companies are doing that to some degree, right? They are for spine centers. They are grading where they can get outcomes data, and they're getting it more and more. They're grading sort of the top 20%, that have the best outcomes by whatever methodology. Blue Cross Blue Shield is doing this, whatever methodology they use. So, right, they're taking a pretty broad swath. So they're not saying only the top 1%. They're trying to be pretty broad. And then within that group, they're economically credentialing that, right? So they're saying, we're only talking about good centers. We're not trying to send our patients to centers that aren't in the top. But of those top ones, this group does a total hip for this price, and this group does a total hip for this price, right? So I think that we will get that to some degree from payers. I think that our academy resists that because the bulk of their membership are people out in, standard practice who don't want their ability to do things to be restricted. And, so I think it's politically problematic. And I guess the other piece is I think that we then have to prove that these things done in centers have a lower complication rate or less problems, right? Intuitively, that sounds like it might work, but I don't think it's good enough that it might work. I think you'd really have to demonstrate that it works for, various interventions. It's going to be a hard thing to do politically. I think it makes sense theoretically.
Let's take one final question from our other Ritchie lecturer, and I'll promise Praveen that I'll carve this time out of my talk. So go ahead, John.
Yes, Steve, thanks so much for a great talk, very edifying. I completely agree with everything you said. The thing that I want to bring up as sort of devil's advocate is you mentioned that, back 30 years ago, patient-related outcomes weren't really looked at, and everything was in terms of surgeon outcomes, fusion rates, and overall assessment of how the patient's doing. Do you think in a way, though, that maybe the pendulum has swung too far the other way, and that these patient-related outcomes do give you a good idea of what's going on from a patient perspective, but what I often see is that that doesn't tell the whole picture either. And so for whatever reason, if a patient's happy, then on that day, all their answers are going to be more positive. A lot of times I walk into the room where the patient, quote unquote, is filling it out, and it's actually the spouse or the family member that's filling out these things more than half the time. So I'd just be interested to hear your thoughts on that.
Yeah, so it's far from perfect, right? And there's a lot of, so that's a reasonable example. It's not the example that comes to my mind would be, you know, that things that will change over time may not be reflected in that, right? So if you have a non-union, right, and broken instrumentation, and the patient, you know, feels okay, but maybe that's going to, you know, have progressive deterioration. Maybe that's not a good example. I'll give you a different example. We looked at complications, okay, and it turns out that for a lot of complications, there isn't really a dramatic difference in 2-year outcomes between patients who have complications and who don't have complications, right? And so for some things, that makes a lot of sense, right? If you have a urinary tract infection with your scoliosis surgery, is that really going to change where you are at 2 years? No, it's really not, right? But if you have a heart attack, okay, you know, at 2 years, you're over that heart attack, you feel fine, you answer your outcome measures, and you look perfectly good, right? But the next heart attack, instead of it not being a big deal, you die, right? That heart attack was a real change that mattered that isn't reflected in your patient-based outcome measures. So absolutely, it's not perfect. And, you know, I think that we need to balance those things, but it's what we're going to be measured against, whether we like it or not, whether we think it's good or not. So we can do more, but if we don't do that, we're not going to be able to argue for the things that we think are good.
Okay, thank you so much.
In the interest of keeping us on time and also keeping the program more interesting than hearing from me, I'm going to ask Dr. Gamber to actually come up and talk about clinical issues in rehabilitation in the aging spine. So thanks for being here, Bob.
Good morning. I'm just going to kind of give you a clinical perspective and